I want to thank you all for your attendance at this meeting, and it's really your presence here, I think, makes this a success, and I'm really pleased that we've been able to translate our initial symposium that we held last year with a distinguished David Menon to a second meeting, and a really exciting and program that we have from an international and national faculty. So I hope you do enjoy the day. And I will focus on, as Manoj was saying, I will focus on what neuromonitoring us to augment our clinical examination and find out what it can tell us to help us in our basic critical care management. These are my disclosures. I want to take this opportunity to thank particularly the St. George Sutherland Medical Research Foundation for their support, as well as the funding support that I've received from the University of New South Wales. And I also want to thank, of course, the team of people that I work with here at St. George Hospital, John Myberg, Manoj, of course, and I mustn't forget Teresa Jakes, who has led the unit for the past 30 years now. And we're in this very exciting development phase, as some of you will know, with a new critical care unit that's being currently built. I just want to start off by just perhaps telling a few stories about some cases that we've had, just like Manoj has done. Cases that those of you who work at St. George might know, just to illustrate some of the points that I want to make. Firstly, this is an 88-year-old man. Age is no longer a limit for intensive care, as most of you will know. He presented with a stroke and was rapidly rushed to Liverpool Hospital to have an attempt at thrombectomy. You can see here that he had a CT perfusion study which showed a large thrombus affecting his middle cerebral artery on the left side with an increasing area of demarcation demonstrating reduced cerebral blood flow. And he proceeded to thrombectomy. Unfortunately, despite successful recanalization, he continued to have neurological symptoms and failed to regain consciousness and died a week later. Here's another case of a 60-year-old woman who had a spontaneous subarachnoid hemorrhage, as you can see, from a very large anterior communicating artery aneurysm. She underwent craniotomy and clipping of that aneurysm and was managed with CSF drainage, nimodipine, with no evidence of raised intracranial pressure, but failed also to regain consciousness. She was later tracheostomized and transferred to the ward, with EEG following up showing that she had generalized slowing consistent with diffuse cerebral function. Here's another patient who presented a few months ago, a young man, 54 years old, who suffered an out-of-hospital cardiac arrest, had an over 60-minute downtime, unfortunately. He was cooled to 33 degrees, but developed myoclonic jerks and fixed dilated pupils within 24 hours. And he progressed to brain death and unfortunately had to be referred for organ donation. And finally, this is a young woman, a student actually from China, who was crossing the street and was struck by a motor vehicle, an often too frequent occurrence that we see. She had intractable raised intracranial pressure for the first week in ICU, but did not proceed to a decompressive craniotomy. Her temperature was not strictly controlled, but she had modest hypothermia at the time, which was maintained for the first week of treatment. There was no evidence of any extracranial injury, but she remained in a protracted vegetative state, but that later shows some neurocognitive improvement and eventually made it to the ward and went on for rehab. Central to all these cases is an alteration in blood flow. I think that's a common theme pervading all these cases, albeit with different time courses. Abrupt in the case of a stroke, progressive decline over 10 days to 2 weeks in the case of a subarachnoid hemorrhage, and fluctuating as shown here in the case of a severe traumatic brain injury. And the question arises as to what extent this was impaired or inadequate, how much it impacted on outcome, and how it might have been perhaps altered or influenced by treatment had more information been available to us in each of these cases. We know from animal and human studies with advanced imaging techniques that focal and global ischemia is common in traumatic brain injury. And I mentioned David Menon, and this is from his group in Cambridge, showing how they were able to quantify the ischemic burden after traumatic brain injury. And here he's able to show evidence of very high oxygen extraction, as shown by the light intensity in the middle PET imaging, indicating evidence of ischemia, and similarly on the right side with the presence of the voxels in red showing areas where the oxygen extraction fraction was very, very high, greater than 75%, indicating that the cells in the brain are trying to extract as much oxygen as possible. This was further demonstrated by a group of investigators from Osaka University who simply just showed that cerebral blood flow was profoundly depressed in early phases of traumatic brain injury, and it persisted for up to 6 weeks after injury. But when compared to sort of standard matched volunteers, if that cerebral blood flow improved over that time, then these patients achieved a significantly better outcome than those who did not. So look, the hallmark of acute brain injury are the events that lead to secondary brain injury, and accordingly fundamental to the modern management of acute brain injury is the prevention, minimization, and treatment of the secondary brain injury. And I'm not going to go into too much detail here, apart from saying that there are two main components that I believe we need to be mindful of. And firstly, there is an important reduction in substrate delivery, which the brain metabolism relies on. It relies on a constant delivery of substrates, principally glucose and oxygen, which are essential for its function. And in a ischemic state, there's a decrease in blood flow, which causes an inadequate supply of these important substrates. ATP, which normally relies on this, then decreases ATP production from the citric acid cycle, and the cells attempt to compensate by increasing the turnover of glucose using the anaerobic pathway of glycolysis. And there's an increased production of lactate as a consequence. Secondly, we also understand from metabolic studies now, with the aid of cerebral microdialysis, that there is a state of what we call metabolic failure, where cells are no longer able to utilize the substrates that are being supplied to them, a condition that we often refer to as an acute energy crisis in the brain. And I discussed that in my lecture from last year's symposium, for those of you who were there. And just to quickly go over that again, here was a study performed by Paul Vesper's group in UCLA, and he's also got the same tools and imaging, fancy imaging that's available to him as in Cambridge. And he was able to demonstrate that by using PET-derived measures of glucose and oxygen metabolism, that there was about a 25% incidence of metabolic crisis in this cohort of traumatic brain injury. And only 1 out of 19 patients had any evidence of ischemia. So what does it mean? On the one hand, you've got a group of patients where there appears to be some problem with oxygen utilization, and on the other hand, you've got a very large ischemic burden. What does that tell us about the patients that we're dealing with? Clearly, there's a really heterogeneous group of patients that we're having to deal with, particularly in acute traumatic brain injury. And this is, I think, where multimodal neuromonitoring comes into play. It can help us ensure that we understand what's going on, create the optimal environment for which the brain can repair itself, and help us in our manipulations of systemic physiology that we do readily at the bedside, like hemodynamics and ventilation, and understand how that might impact on cerebral physiology and metabolism. And of course, I'm not simply talking here now about inserting more probes and bolts into people's heads, or taking them down to the radiology department and performing sophisticated, fancy brain scans. Rather, I'm just talking about the judicious use of very selected modalities to help us present the picture or paint the picture of what exactly is going on in our patients, and then targeting the right treatment for the patient. Something that we now call in our circles, and that's talked a lot about in our international conferences, the concept of precision medicine, personalized medicine to tailor the treatments to our patients. So what are the main modalities of neuromonitoring that we currently have at our disposal? And I'll go through each of these in brief, from basic intracranial pressure monitoring all the way to the more sophisticated tools that we have available now at our disposal. Since monitoring intracranial pressure is fundamental to understanding intracranial hemodynamics, and if abnormal and untreated, can lead to poor neurological outcome, it seems important that we should talk about it in the first instance. Because ICP and CPP guided treatment has now become the standard of treatment worldwide. There is substantial clinical evidence for its use. There's strong evidence that raised intracranial pressure is associated with poor outcomes, especially if it's resistant to treatment, and it's a relatively low-risk treatment with a high yield. However, you might be surprised to learn that even in the latest 4th edition of the Brain Trauma Foundation Guidelines, which was published last year, really indicated that there is a broad low quality of evidence supporting the use of intracranial pressure in this setting. One of the most recent studies that have been published looking at the use of ICP monitoring, of course, was the BEST TRIP study undertaken by Randy Chestnut from Seattle. And this was the latest study contributing to the body of evidence. And although it was a study done by an esteemed and well-established neurosurgeon from the United States, the study was actually conducted in 2 developing countries in South America, Bolivia and Ecuador. Nonetheless, I think it was done very, very well, and accordingly was published in the New England Journal in 2012. And this was really a study that compared protocolized treatment guided by ICP monitoring to one based on repeated clinical examination and imaging without ICP monitoring. And surprisingly, or perhaps not surprisingly, there was no significant difference between the 2 groups in terms of the primary outcome, which was a composite measure of performance across 21 different functional and cognitive variables. And mortality at 3 and 6 months was also no different. Interestingly, the number of brain-specific treatments, in other words, things like hyperventilation or osmolar therapy, was actually higher in the group that relied on clinical examination and imaging alone. What does this tell us? I mean, is this something that we should take on board and stop doing intracranial pressure monitoring? Well, I think not. I mean, I think it's important to recognize that this RCT had good internal validity. It probably lacked external validity. And it really didn't test the treatment of ICP per se, but rather essentially compared 2 management protocols. And remember, ICP is a really complex variable with multifactorial factors contributing to the figure that we get at the end of the bed on our monitors. And to think that manipulating a variable like ICP can somehow lead to better outcomes would be probably a gross oversimplification of what this was all about. And I think this is a principle that we need to remember by when we use any other neuromonitoring device. This was just the KM curves just to show that. Now, what about cerebral blood flow then? We're on to cerebral blood flow. You know, most of our brain-oriented therapies that we do in the critical care are designed to maintain cerebral blood flow, and I highlighted that with the cases that I presented at the beginning. And this is managed in clinical practice, yet it's not something that we routinely measure. Despite its importance and that it is fundamental to the effectiveness of treating our patients in critical care. Knowledge of cerebral blood flow, as well as an understanding of the regulation of blood flow, has been made possible in recent years by the introduction of more sophisticated bedside monitoring techniques, particularly optical techniques, which I shall tell you about and which Anders is going to go into some greater detail on, in addition to the more traditional imaging techniques using radiology and PET scanners and MRI and so forth. We know that cerebral blood flow, when it falls to a critical level, brain function starts to deteriorate quite markedly. And we can measure this on an EEG, as well as using our more invasive blood flow monitoring devices. Cerebral blood flow is determined by a number of factors, in particular the driving pressure of what we often refer to at the bedside as the cerebral perfusion pressure, or the CPP. And since blood doesn't behave as a Newtonian fluid, and flow is essentially not laminar, it's also influenced by its rheology and viscosity. And so the hematocrit is an important factor here. And of importance to the control of blood flow are factors that govern the diameter of the cerebral blood flow, particularly the vascular tone, which is responsible for the modulation of cerebral perfusion. And we can broadly categorize this into either neurovascular coupling, which is determined by metabolic demand, or the perfusion pressure, which is what we commonly refer to as cerebrovascular autoregulation. And I thought it's prudent to also mention at this point the influence of temperature. This was studied and demonstrated back in the 1950s by this study by Rosmov and Holliday, which showed how cerebral blood flow diminishes with decrease in temperature. And since the arteriovenous difference is largely unchanged, by inference, hypothermia doesn't produce hypoxia in brain tissue. And you can see here on the graph on the right where the cerebral metabolic rate of oxygen, in other words, the oxygen consumption, falls with temperature as well, to the point that nearly 50% decrease in oxygen consumption correlates with the decrease in cerebral blood flow. So cerebral blood flow is inversely related to the total resistance of the entire cerebral vasculature, as shown here in this simple equation. And CPP, in turn, is determined by the pressure gradient from the systemic to the intracranial pressure. And by neurogenic, myogenic, or metabolic mechanisms, we're not really entirely sure, but maybe a combination of those factors, cerebral blood flow is regulated at a microvascular level to maintain a relatively constant blood flow to the brain over a wide range of systemic pressures. As long as that CPP remains in the upper and lower limits of autoregulation, blood flow will be maintained. Now, how do we measure cerebral blood flow? Well, measurement of blood flow can clearly provide valuable information, and some of you might laugh at this, but this is actually exactly how blood flow was measured in the not too distant past. But now, of course, we have much more sophisticated techniques. And just broadly, I can just, without spending too much time into the physics behind all this, there are three broad ways of measuring cerebral blood flow. The first is to use a global measurement shown on the left, where we use a diffusible tracer and relatively inert tracer as our means of measuring blood flow. And this is the principle by which xenon CT scans are used, because xenon's a relatively inert and diffusible liquid that's readily dissolved into absorbed into the cerebral circulation. And you can measure cerebral blood flow this way using very nice imaging techniques. And this was what was used for many, many years. Of course, another method is what we use is using an arterial tracer to help us understand perfusion to the brain. And this is the basis by which our modern imaging techniques like CT perfusion that I was showing you earlier, that's the principle on which it's based. And it uses the principle of an injected contrast agent to determine the changes in tissue attenuation in the brain over time. And using special post-processing techniques, we can get a nicer picture of exactly how the brain is being perfused. MRI is also the same. Again, I won't go into too much detail apart from showing that this technology is now becoming more and more available. PET imaging I talked about earlier, which remains the domain of high-end research centers, but has really provided us great insight into our understanding of the brain and what happens when it's injured. Finally, the third modality, which is the one that we will focus a little bit on now, is the role of Doppler effect, using ultrasound or optical waves to interrogate the brain using optical and ultrasound waves. And this results in, as you know, when you shine a wave into any tissue, if there's moving blood vessels, this will result in intensity fluctuations that cause a frequency shift, which can be received and detected by a detector to translate into what might appear to be flow. And this is the principle behind the technologies such as laser Doppler flowmetry, which is something that's largely research-based, but which was used for many, many years. to help us in understanding cerebral blood flow changes. And now, more readily at the bedside, near-infrared spectroscopy, which uses light in the near-infrared range to give us an idea of oxygen saturation in the brain using oxyhemoglobin as a tracer. And these changes correlate very well with other modalities like laser Doppler. There's a new device that's currently available that I'm hoping to get for St. George, and it's a device that uses a hybrid NERS technology with ultrasound, using ultrasound to sort of tag the red cells and using NERS to help measure blood flow and give us a more direct measure of blood flow rather than just a relative one. Transcranial Doppler has been around for many, many years, and I won't say too much about it, apart from the fact that it yields, again, very useful bedside information, not so much of blood flow, but of blood flow velocity. Whilst its main use is often regarded as in the detection of cerebral vasospasm in patients with subarachnoid hemorrhage, like the lady I told you about at the beginning, I think its utility is in particular giving us another measure of cerebral blood flow that we can use to assess how the brain is autoregulating in times of illness. There we go. A little break. What's the relationship between cerebral perfusion, pressure, and cerebral blood flow? Now, because ICP monitoring is what we normally use, and it's a universal monitoring device that's readily available, and because of its direct relationship with cerebral blood flow, as I've already mentioned, CPP is often used as a bit of a surrogate for cerebral blood flow. But can it be a true surrogate of cerebral blood flow? This relies on the relationship between cerebral perfusion and cerebral blood flow. And when we've got an intact cerebral vascular autoregulatory system, this doesn't apply because the relationship is not linear, as shown on the graph on the left. Linearity, in other words, if you've got a high correlation between cerebral blood flow and cerebral perfusion, would suggest that the autoregulatory system has actually failed. And this is the fundamental basis for our current clinical practice for traumatic brain injury, for instance, where we try to drive the cerebral perfusion pressure in the hope that this might achieve adequate cerebral perfusion. But what is the critical threshold that we should be targeting? And can it be determined at the bedside? Or is it something that we can just generally apply it to all our patients and just say, look, let's just aim for a CPP of 60, and it's one size fits all? Is that going to work? Well, I think, I might just skip on to the next slide. I think since autoregulation is one of the most important mechanisms of brain protection, particularly after conditions like traumatic brain injury and stroke, I think a good clinical monitor of cerebral autoregulation should inform us of the position on the autoregulatory curve, or Lassen's curve as it's referred to, relative to the limits of autoregulatory function. And we'll hear a bit about that from Anders, I think, so I won't go too much into it. But it's certainly just to say that as long as autoregulation is function, the brain is protecting itself against ischemia. And when it's not, then it's vulnerable to the effects of cerebral perfusion. And this is where TCD, I think, can be very, very helpful, using an approach to assess autoregulation at the bedside by determining how, for any given change in perfusion pressure or mean arterial pressure, how this is reflected by change in blood flow. And I think using the flow velocity on a transcranial Doppler can help us understand whether the CPP-induced changes result in a change in cerebral blood flow. And this can be done either using a static approach or using a dynamic approach where we use much more rapid changes in mean arterial pressure to determine that effect. And using cerebral autoregulation, we can achieve these indices of autoregulation, such as the mean velocity index, which is simply calculated from consecutive time-weighted average samples of flow velocity in relation to cerebral perfusion or mean arterial pressure. And a positive association is associated with disturbed autoregulation, whereas A negative or zero correlation actually refers to an intact autoregulation, as shown here. And similarly, the relationship between intracranial pressure and cerebral perfusion can also be assessed using an index to determine what the optimal cerebral perfusion pressure is. And this really just shows how the flow velocity here measured by TCD fluctuates wildly over time, and yet when you plot the mean velocity index against the arterial pressure, you can see a nice parabolic curve, and the lowest point where the parabolic curve meets is an indication of where the CPP is considered to be optimal. And in this case, it's about 96 millimeters of mercury. And studies have shown, like the study from Cambridge, that have shown when you target optimal CPP in patients after traumatic brain injury, you can achieve a much better outcome. And here, there was a significant improvement in long-term outcomes in patients where patients had their CPP targeted closer to the optimal CPP, and on the other hand, patients who had the greatest deviation from the average CPP, to the optimal CPP had worse outcomes. So what about more modern techniques of measuring cerebral blood flow? I just wanted to highlight that there is another tool available called the Hemodex, which uses a different concept using thermal diffusion with a heater at the tip and a temperature sensor just proximal to that, and it relies on the thermal conductivity of the brain. Studies in this area have shown that there's a close linkage between cerebral blood flow and brain tissue oxygen levels, so suggesting that brain tissue oxygenation is reliant in part on regional cerebral blood flow, and this is probably would come as no surprise. What about oxygen monitoring then? Well, oxygen, as I mentioned, is one of two key substrates for cellular metabolism in the brain, and hypoxemia is a major factor contributing to secondary brain injury. Therefore, monitoring of oxygen delivery would seem to be a logical place to start. How can it be measured? Well, there are three modalities that are pointed out here. I might start by talking about jugular venous bulb oxygen monitoring, if only because of its historical importance. We don't use it much now at the bedside. It's less widely used. But nonetheless, studies in this particular area from the 1990s, for instance, highlighted the importance of oxygen delivery to the brain. And this particular study by Claudia Robertson's group in Houston, Texas, in traumatic brain injury patients showed how the occurrence of desaturations of jugular venous oxygen was associated with higher mortality and poorer outcomes at three months. And patients who suffered more frequent episodes of desaturation fared worse. And this was also associated with cerebral blood flow. Surprisingly, though, well, not surprisingly, I guess, because the evidence is there, jugular venous oxygen saturation remains the only modality for monitoring oxygen that's recommended by the Brain Trauma Foundation guidelines. Brain tissue oxygen monitoring has actually been demoted in that regard, but I think more studies are clearly required in that area. I just want to touch on NERS because that's the other modality that I've already mentioned. It's probably less useful as a tool for measuring cerebral oxygenation because of concerns about its technology and the limitations that it has of measuring perfusion of the brain, and also the fact that there's probably concern that there is considerable extracranial contamination. In other words, blood flow in the scalp can contaminate the signal that you're getting in the probe, and you're not really getting a true reflection. Plus, if there's underlying brain injury, that could also affect the signal that you receive in the probe. But there is a newer device produced by a Japanese company, Hamamatsu, which is able to measure what we call a total oxygenation index using a technology called spatially resolved spectroscopy, which is able to more specifically interrogate the intracranial blood volume and have less issues with extracranial contamination. So the technology is clearly evolving, and we're going to be able to have these non-invasive tools at the bedside, which I think is probably where things are going to go for its wider applicability. Brain tissue oxygen measurements now can be done at the bedside, and we use a Lycox probe to insert it into the brain parenchyma to give us an idea of the partial pressure of oxygen in the brain. It provides a measure really of the balance between oxygen supply and delivery, oxygen delivery and utilization. And whilst it's largely a focal sensor with a very small area that it interrogates, if you place it into a relatively normal brain or brain with diffuse brain injury, it's probably a reasonably good measure of global oxygenation. What are the studies that have contributed to its use? Well, here's one study from Peter LaRue's group in Philadelphia, which compared the use of brain tissue oxygen-guided treatment of traumatic brain injury with a cohort of historical controls. And in this particular study, he was able to demonstrate that using a strategy using brain tissue oxygenation, mortality can be improved and long-term outcomes can also be improved. But what we really need is a randomized controlled trial. And this study also didn't really standardize what methods were used to try to augment or maintain cerebral oxygenation. Probably the main ones are either CPP augmentation, which is what we do anyway, increasing the FiO2 or perhaps increasing oxygen transport by giving a blood transfusion, and other methods like sedation and other basic measures that we would normally apply. And in terms of randomized controlled trial, in fact, there has been a study that's been done. It's a phase 2 study referred to as the BOOST 2 study, which was really a feasibility study and a safety study looking at the application of this type of approach to managing traumatic brain injury. It was a multi-center RCT involving 10 sites in the United States with 2 arms, either interventions triggered by ICP or one triggered by ICP or a brain tissue oxygen that was less than 20. And they used 4 different tiers of standardized treatments to intervene. The inclusion criteria were basically any patient who required ICP monitoring that was non-penetrating, and they were randomized within 12 hours. The primary outcome was a Glasgow outcome score, an extended Glasgow outcome score measured at 180 days, and they looked at other indices as well. And just very quickly, it showed that there was no difference in outcomes between the 2 groups. Nonetheless, it did show that the patients who were treated with oxygen monitoring had a lower proportion and average amount of time that they experienced a hypoxic oxygen state as measured by the Lycox probe. There was no difference in the ICP data between the groups or variations between the 2 groups. And as I mentioned, there was no difference in the so-called non-futility outcomes. So in conclusion, traumatic brain injury guided by this modality seems to be feasible. It could potentially reduce duration of brain tissue hypoxia and may contribute to reduction in mortality and increased good outcomes. And I think hopefully will be part of a broader, perhaps multinational study in the coming months or years. And just finally, I won't spend too much time talking about microdialysis, other than to say that here's another tool that we have available that we can interrogate the brain more accurately, much like we do a blood gas in our patients, to get a little bit more information about how our treatments are being delivered. And using this particular technology, it's become a reality at the bedside with very good temporal resolution because we can monitor it continuously. And the technology is now very readily available. It's relatively minimally invasive and provides us with very useful biomarkers of what's going on in the brain, in the injured brain in particular. The key is this lactate to pyruvate ratio, and we can see here that when the lactate to pyruvate ratio is very high, it's an indication that the brain is in metabolic distress, and intervention to try to address that, for instance, in this case by increasing the perfusion pressure, can result in improved oxygen delivery and resolution of that process. And finally, EEG is a tool that's clearly readily available, but you might be interested to know that EEG can also provide us with a broad idea of cerebral blood flow. We know that in low cerebral blood flow states, the EEG tends to reduce or rather the frequencies the faster frequencies tend to be lost, and there's an increase in slower frequencies. And then as it drops below the critical threshold of about 10 to 12 mils, the EEG becomes silent and the cellular damage becomes irreversible. And you know, we use diffusion weighted imaging with MRI scan to help determine whether our patients have suffered a stroke, even though the CT brain scan is normal. By using EEG, you can actually interrogate the problem much quicker than you can with MRI scan. So look, in summary, we now have at our disposal a variety of methods for monitoring the brain, measuring not only ICP, but also substrates of cerebral metabolism, such as oxygen and glucose, as well as other biomarkers, which can hopefully help us elucidate the underlying mechanism of injury. And these modern bedside measures of cerebral blood flow, for instance, can help us monitor changes in autoregulation to help us tailor our treatments more specifically to our patients. Where to from here? Well, we're undertaking a feasibility study, as you know, in traumatic brain injury, looking at 2 different temperature targets. And by using neuromonitoring tools that are at our disposal, we can perhaps understand more clearly the mechanistic effects of our interventions on our patients. And this is a very exciting time, and I'm really looking forward to working with those of you at St. George, and of course Manoj and Anders in this area. And without further ado, I might pass it on to Anders, and just mention that next year Manoj, myself and Paul Young and Anders will be running an international hypothermia meeting in Sydney, and we'll give you more information about that in due course. Thank you.